All right, welcome to this explainer. We are executing a very rapid introduction today because we have a massive amount of critical ground to cover. We are establishing a strict peer-to-peer clinical tone right out of the gate for this high-yield 270 plus ophthalmologic and systemic pathology simulation. This is all about isolating exact mechanisms and making definitive clinical decisions under pressure. Let's dive right in. Module 1. Anterior ischemic optic neuropathy and arteritis. In the case of anterior ischemic optic neuropathy, time is tissue and time is vision. So, let's break down the pathophysiology of giant cell arteritis, or GCA. Listen, this isn't just a bad headache. It's a subacute granulomatous vascular disruption. Specifically, it heavily targets large vessels, impacting the extracranial branches of the carotid artery. But the absolute critical danger here lies in the granulomatous inflammation of the posterior ciliary arteries. When these occlude, it leads directly to ischemia of the optic nerve. The result? Permanent monocular blindness. Now, take a look at the clinical dichotomy here. We must distinctly separate the classic systemic symptoms from the catastrophic ocular manifestations. Systemically, you're looking for patients strictly over age 50, peaking around 75, who present with unilateral or bilateral temporal headaches, exquisite scalp tenderness, and that highly specific jaw claudication. But the ocular column is where the true emergency lies. Amaurosis fugax, that transient vision loss, is the warning shot. If you ignore it, it progresses to sudden, painless, irreversible monocular blindness due to anterior ischemic optic neuropathy or central retinal artery occlusion. This brings us to a crucial point: your absolute management mandate. If a patient presents with visual symptoms suspicious for GCA, immediate high-dose intravenous methylprednisolone is required. Period. Delaying corticosteroid therapy to await an elevated ESR or CRP, or holding off to get a temporal artery biopsy is a catastrophic clinical error. You literally have at least a week on steroids to perform that biopsy for confirmation. You absolutely do not have time to wait when a patient's vision is on the line. Let's isolate the variance between GCA and polymyalgia rheumatica, or PMR. These two are highly associated. In fact, about 50% of GCA patients also have PMR. Both present with an elevated ESR, often shooting over 100. However, PMR is characterized by intense inflammation of the periarticular shoulder and hip girdle and is managed with low-dose prednisone. GCA, defined by jaw claudication and the threat of vision loss, uniquely dictates emergent, high-dose steroid intervention. Okay, let's put this to the test with our first integrated clinical vignette. A 72-year-old female presents with transient visual obscurations, scalp tenderness, and jaw pain during mastication. Her ESR is pending. What is the most appropriate next step in management? We are specifically testing the immediate management mandate here. Let's exhaustively deconstruct these 5 distinct options. Number 1, awaiting ESR/CRP. That's incorrect. The laying here guarantees irreversible blindness. Number 2, temporal artery biopsy. While it's the gold standard for diagnosis, it's incorrect as the next step because it delays critical treatment. Number 3, immediate IV methylprednisolone. This is correct. It is the absolute, non-negotiable pharmacological mandate to prevent retinal artery occlusion. Number 4, topical corticosteroids is incorrect. This is a systemic large vessel vasculitis. It requires systemic therapy. And finally, number 5, acetazolamide is incorrect. That's a carbonic anhydrase inhibitor used to decrease intraocular pressure in conditions like glaucoma. It's completely ineffective for arteritis. Moving right along to Module 2, post-operative endophthalmitis versus anterior uveitis. We are now shifting to post-operative emergencies, specifically mastering the evaluation of anterior chamber accumulations. Applying our diagnostic decision matrix, we must perfectly contrast bacterial endophthalmitis against anterior uveitis, which is also known as iritis. Endophthalmitis is driven by exogenous bacterial inoculation. We typically see this within days to weeks post-cataract surgery or after penetrating ocular trauma. It presents with profound painful vision loss and a highly visible hypopyon, which is that layered, purulent debris in the anterior chamber. Conversely, anterior uveitis presents with photophobia and a constricted or irregular pupil. It's an inflammation characterized by suspended inflammatory cells and flare. Importantly, it's often a systemic mimic, strongly linked to HLA-B27 spondyloarthropathies or sarcoidosis, rather than direct inoculation. Let's visually anchor this concept. What you're seeing here in this slit lamp examination is that classic dust in a sunbeam appearance. This represents suspended inflammatory cells and protein flare in the aqueous humor, which is highly indicative of iritis. Recognizing this exact pattern is absolutely required to rule out the heavy, layered, purulent hypion that defines a severe endophthalmitis. And that brings us to the next high-yield mandate. Suspected bacterial endophthalmitis is an absolute ophthalmologic emergency. It mandates immediate intravitreal antibiotic injection. Specifically, you need broad-spectrum coverage with vancomycin and ceftazidime, alongside a potential vitrectomy. Failing to execute this aggressively leads to complete anatomical and functional loss of the eye. Highlighting the clinical variance here is critical because your pharmacological management diverges entirely based on the etiology. Bacterial endophthalmitis requires emergent intravitreal antibiotics to eradicate an active intraocular infection. Anterior uveitis, being a sterile immune-mediated inflammation, is managed primarily with topical corticosteroids. Let's test this with our second vignette. You have a patient who is 5 days post-phacoemulsification, presenting with severe eye pain, conjunctival injection, profound vision loss, and a visible hypopyon. The clinical evaluation here requires you to isolate the pathology and select the correct aggressive therapy. What is the definitive management step? Let's rigorously eliminate the distractors. Option 1, topical corticosteroids. Incorrect. This treats iritis but would dangerously exacerbate an active bacterial endophthalmitis. Option 2, intravitreal vancomycin and ceftazidime. This is correct. It provides the mandated immediate broad-spectrum intraocular coverage. Option 3, IV methylprednisolone. Incorrect. This is for optic neuritis or GCA, not a purulent bacterial infection. Option 4, oral aciclovir, is incorrect. That treats HSV keratitis, which presents with corneal dendritic ulcers, not a layered hypion. And option 5, observation with warm compresses. Incorrect. That's the management for a benign eyelid sty, or a hortodulum. All right, Module 3, opportunistic retinal necrosis in immunodeficiency. We are now targeting the evaluation of ocular manifestations in advanced immunodeficiency, specifically focusing on AIDS patients with CD4 counts below 50. Deploying our next data matrix, we've got to separate CMV retinitis from ocular toxoplasmosis. In a patient with a CD4 count strictly under 50, CMV presents with painless, progressive vision loss and floaters. Fundoscopy reveals the classic pizza pie retinopathy, full-thickness necrosis with dense white perivascular exudates and prominent hemorrhage. Contrast this with Toxoplasma gondii, which typically occurs with a CD4 under 100. Toxo presents with severe anterior chamber inflammation and yellow-white elevated chorioretinal lesions situated right next to old pigmented macular scars. The pharmacological rules here are very discreet and, frankly, heavily tested. CMV retinitis necessitates immediate therapy with either intravitreal or systemic anciclovir or oral valganciclovir. Ocular toxoplasmosis mandates an entirely different regimen, pyrimethamine and sulfadiazine. And crucially, this must be paired with folinic acid, or leucovorin, as a rescue agent to prevent severe hematologic bone marrow toxicity caused by the pyrimethamine. Let's clarify one more critical retinal differentiator before we wrap up. You must differentiate CMV retinitis from HSV or VZV retinal necrosis based on a singular, high-yield clinical variable, pain. CMV retinitis is notably painless. HSV and VZZ, on the other hand, cause acute retinal necrosis syndrome that's characterized by severe, painful ocular inflammation and widespread, pale, necrotic retinas requiring acyclovir. All right, let's launch into our final integrated vignette. An HIV-positive patient with a CD4 count of 35 presents with floaters and painless vision loss. Fundoscopy reveals perivascular hemorrhagic exudates without prominent anterior inflammation. We need to identify the exact opportunistic in this advanced AIDS patient and select the correct therapy. Let's exhaustively reject these high-noise systemic distractors. Number 1, pyrimethamine, sulfadiazine, and leucovorin. Incorrect. This treats toxoplasmosis, which features chorioretinal lesions near old scars, not prominent hemorrhagic exudates. Number 2, valganciclovir or ganciclovir. This is correct. This is the exclusive, mandated therapy for the painless hemorrhagic CMV pizza pie retinopathy, seen at a CD4 of 35. Number 3, high-dose IV TMP SMX. Incorrect. It's the targeted therapy for PJP pneumonia. Number 4, clarithromycin and ethambutol. Is incorrect. This treats disseminated MAC. And number 5, fluconazole, is incorrect. This is utilized for candidiasis. Let's terminate the clinical simulation right here by cementing the three absolute pharmacological mandates we covered today. 1. Visual symptoms in giant cell arteritis equal immediate IV corticosteroids. 2. Postoperative hypopyon in bacterial endophthalmitis equals intravitreal vancomycin and ceftazidime. 3. Painless hemorrhagic retinopathy in an AIDS patient equals CMV retinitis, mandating ganciclovir. Master these discrete steps, simulation complete,